So, oh, okay. So, thanks for coming on and taking the time. So I know how busy you are. So I guess, like, in terms of chiropractors are often some of the first people that pick up a scoliosis. We see a lot of people. So in terms of progression of scoliosis and what ages and what degree of a curve should we monitor closely compared to sort of referring on?
Yeah. Well, scoliosis is quite a big topic. It's one of the reasons I've sort of avoided doing a talk like this for so long, because literally we could spend days talking about it.
Yep.
And so your scoliosis comes into different categories, and the answer to that question is different for every single category that's there. So, the first big category is breaking it down into the adult degenerative, and then the pediatric kind of scoliosis. Those are the two big ones.
Yep.
So when you see scoliosis as an adult, that's generally someone who's had scoliosis as a child and has never really had it addressed. And then as an adult, they start to have problems. And the issue with that is that scoliosis is very stiff. It's very ingrained. They've had it for years and years and years, and it's very difficult to deal with. The other type of scoliosis we get in an adult is someone who's had degenerative changes, osteoarthritis, they're developing osteophytes and desmophytes, and then they're developing a sort of a degenerative deformity. And that is a whole different animal as well. So I'm not going to touch on the adult side of things in this webinar. It's something that I think we can address as a separate issue maybe later down the line. So if we kind of look more at the pediatric side, we've got the main categories there are congenital, which is where people are born with a congenital abnormality, and that's either they've got a bar or they've got a hemivertebra, or they've got an area that's not fully segmented.
Yep.
And that can give you fairly extreme deformities. So that's something that if you pick up does need to be seen in the hospital fairly quickly, because we need to image it appropriately. They often need CT scans, MRI scans, and those kind of deformities normally come with a whole host of other problems. So when you see a very young child with a deformity, we are worried then about, do they have cardiac issues? Do they have renal issues? Do they have other neurological issues that are just not manifesting as yet? So that is something that does need to be referred on fairly quickly. And that I'm talking sort of ages of sort of 5 and below.
Right.
So you're really, really young ones.
Okay.
So that's sort of your infantile ones. And those normally come with syndromic issues as well. You then get your juveniles, which are sort of up to the age of 9, sort of between 5 and 9. And they also have a variety. So it's kind of like an early manifestation. There is an idiopathic group within that. But again, we are very much alert for any other problems with these kids. So again, anything in a young child does need to be seen. So I still think the chiropractor can still be heavily involved in their care. I'm not saying don't care for them, but I'm just saying make sure they get seen and screened for all those other issues as well, because those can be fairly significant. And then you've got your idiopathic adolescents. So your idiopathic adolescent very typically notices the deformity somewhere around their early teenage years, sort of age 10, 12, somewhere around there. Often it's not them that notice it. Sometimes it can be their ballet teacher or the gymnastics coach or, a sports coach sees them. Or the other thing is sometimes we have parents come and say, oh, we took photographs on holiday and I've just noticed, looking at, our child in their swimmers that, we've got a problem on our hands. So that tends to be more the adolescent idiopathic. And again, referring those on really depends on the, again, any other associated things. So you have to be up on your examination to pick up on some of the other more subtle signs that could be going on. And then there's the red flags. So if we look at the subtle signs, those are your cutaneous manifestations of spinal dysraphism. So that's a fab sentence that just kind of rolls off the tongue. I get the students to practice it. Cutaneous manifestations of spinal dysraphism sounds awfully posh. And what it basically means is that you've got visible clues that there's something else going on with that deformity. Okay. So we're looking for things like skin discoloration, cafe au lait spots. We're looking for hairy patches, sacral dimples, anything like that that's midline. But we're also looking for things like, do they have a high arched palate? Do they have hearing difficulties?
Yeah.
Do they have a high, what we call a Bateman score? I think you guys call it something different in Australia, but it's signs of ligamentous laxity. So,
Yep.
your thumb down, hyperextension, all of those things.
Yeah.
And also in children, have they had any cardiac surgery? So first of all, if they've had cardiac surgery, it's a sign that they're, prone to these kind of issues.
Yeah.
But also if there's something about surgically opening the sternum that sort of fuses the sternal growth, and then they end up with spinal deformities as well. So there's a very high correlation between pediatric thoracic surgery and developing scoliosis later down the line.
Right. Wow.
Yeah.
I didn't know that.
Yeah, and then there's obviously your neuromuscular scoliosis. So those are people with, sort of your various demyelinating diseases and your cerebral palsies, your syndromes, various other things. And sometimes they also only develop their scoliosis later on in their adult years, or sort of their adolescent years.
Okay, great.
Yeah.
So if we just stick with sort of the adolescents at this stage, that's probably the most straightforward one to go through. So how do we, if they haven't hit their growth spurt yet and we're noticing a curve or curves, how do we monitor that? Like in terms of degrees and that type of thing, where do you start to get worried, and how do we get better at screening those sorts of people?
Yeah. So pretty much we define a scoliosis as anything more as a curve greater than 10 degrees. So it really needs to be 10 degrees or more for it to qualify for the term scoliosis, because we get a lot of referrals through with very small curves.
Yeah.
We're always happy to see them, but they don't really come onto our radar. So anything less than that, I don't really think you need to tell anyone about unless it's progressing rapidly. We would normally then, if they're prior to their growth spurt, we would keep a close eye on them radiologically, measuring cob angles. And we would then start off most probably doing that 4 monthly. And then depending on whether it's accelerating or slowing down, change that schedule. But, at least 3 times a year, we'd most probably x-ray that curve. And we would only do an AP x-ray because obviously we want to limit radiation. So there's no need to do a lateral unless it's a kyphotic deformity that you're measuring. But most scolies, straightforward adolescent idiopathics, they've got quite a flat thoracic spine.
Okay.
We tend to have our alert buttons pushed really when they start hitting the mid-30s. So 35 and onwards, this is a curve we're watching really closely. So they're not hitting the criteria for any surgical intervention, but 35 degrees and upwards is a significant curve. And that's something that needs real close attention. And if they've not hit their peak growth velocity, then obviously you're expecting that a lot is going to change in a very short period. So I think once they start hitting that 30 degrees, I would be then looking to get someone to see them, in the mainstream medical field.
Is there any significance in terms of where the curve starts, or whether the curve is more severe in the lumbar compared to the thoracic, or does that come into it at all?
Yes and no. So you've got your atypical curves and you've got your typical curve. So a right thoracic in an adolescent female is fairly common. It's run of the mill. If you've got a male, then obviously you're thinking this is unusual. And if you've got a left-sided thoracic curve, that's also very unusual. It's not too unusual to get, double curves, so thoracic and lumbar curves. But then it's important to establish, do we have a structural curve, or do we have a structural and a compensatory curve? So those are concepts that some people struggle with a little bit, because, you just look at the x-ray and you see 2 curves and you're like, well, it looks like there's 2 curves. And there are little tricks of working out what's what. So I normally tell people, I normally tell my juniors, if you're wanting to know what's a structural curve and what's a non-structural or a compensatory curve, look at the spinous processes. So if you've got any rotation on the vertebra, it's a structural curve.
Okay.
And then if you've got a curve that's then got your spinous processes in the center, that is not a structural curve. That's then a compensatory curve. And if they've got a significant curve that you can see it on clinical examination, and you can see it with them standing. So I normally do my examination standing from behind, you know, looking at the shape of the curve, looking at the chest wall, looking at what kind of rib hump they've got. And then if I'm kind of thinking, you know, pelvis is asymmetrical, shoulders are asymmetrical, trying to work out what's structural, what's compensatory, you just sit them down.
Okay.
And once you sit them down, you actually level the pelvis. And then you can really get a good idea, because if it's a compensatory curve, it will actually straighten out. And if it's a structural curve, it will remain.
Okay, that's great.
And and that's just because you've leveled the pelvis. If they can't sit, I mean, it's very unusual that they can't, but if not, the other way is to use the foot blocks, you know, the Coleman foot blocks for pelvic leveling, and you just get them to stand on a block or a textbook or something like that if they're more comfortable. And you can assess it that way. But you just essentially want to get the pelvis level, which takes out the compensation. And then if it's a compensatory curve, it will adjust, and then you'll get to see the true structural curve that's there.
Excellent. Okay, so if we're not at the stage, well, I guess the thing is, what I want to talk about is what are the conservative options? Like you've spoke about sort of keeping a close eye on them. What other conservative options are there? And what are the things that sort of trigger you to say, okay, this needs to be operated on? If we can go through that.
So if we go to the end of that, in terms of what needs an operation, we try to delay that as long as possible. But there's a balance, because we reach a point where the curve becomes too great for us to get a really good correction. So we've got to kind of make sure we get in where a correction is still possible, you know, a really good correction is possible. And that's sort of in your adolescent idiopathic. In the neuromuscular group, a lot of our threshold, we tend to operate earlier in that group. And that's because a lot of them have respiratory difficulties, or they have social difficulties. So they can't physically sit upright in the chair because the deformity's got them leaning over, or they're so bent forward, they can't eat, you know, doing the toileting, bathing becomes a big issue. So that's a slightly different group. So with your adolescent idiopathic, it's about doing the surgery when the curve is still flexible enough for us to get a good correction, and that we're limited as to how much correction we can actually do safely without actually damaging the cord. So if the curve has progressed to a certain extent, it limits how much correction we can actually get also from a cosmetic point of view, because a lot of these kids are worried about what it looks like at that stage. So if it's left too late, we can't get it straight. You know, it's just that they'll be left with a fairly significant residual curve, even though it's not going to get worse. So in terms of actually doing something for them, really the big thing is respiratory issues. So making sure their ribs are flexible, making sure their thoracic spine remains flexible, and then also just working on muscle balancing. So a lot of the time, what you're actually seeing with the scoliosis is a combination of lateral and rotation. So in order, you know, if you look at your mechanics of lateral bending, which is what a scoliosis is, it's a coronal plane deformity. There's no such thing as pure lateral flexion. That's actually a combination of forward flexion and rotation. And it's that rotary part that is actually the biggest part of that deformity. So, you know, rotary stretches, rotary, you know, not rotary manipulation, but, you know, sort of working on the stiff side versus the looser side. And positioning is very good. So some of the times we get them positioning over Swiss balls, get them positioning over foam rollers. The idea is what you want to do is work out what is the most involved rib. So what level rib is correlating with the point of that convexity and the concavity. And then you want to put the convexity down and stretch over that, but try and position the roller under that specific rib.
Right. And does that make much of a difference? Like,
so we're into contentious waters. Okay. Is chiropractic going to straighten a curve?
No.
It depends. It depends. So if you get someone like some of the juveniles, you get two groups. So you get the progressive deformity, and you actually get the correction deformity. So some kids develop a curve and then straighten up. And
Okay.
we don't quite know why that happens, but there are some curves that do actually straighten up, and they tend to straighten up whether we intervene or not. But they just, as we watch them, the curve just starts reversing. There is some theory as to it being sort of growth plate related on the actual vertebral growth plates themselves, but we don't really have the evidence for that. We don't even really know what causes the idiopathic
Yeah.
curves either. There's lots of theories, but no actual solid evidence.
Okay.
So in that group, they would do very well being supported through that phase, being educated about posture. All of those things really, I feel, has a great benefit for those kids. And you're never going to know, are they going to, progress, or are they going to correct? But
Yeah.
either, it makes no difference really. You still need to care for them in the same way.
Yeah.
And then the decision gets made, however the spine behaves itself.
Okay.
If you've got a person prior to their maximum velocity growth spurt, they are candidates for bracing. Okay. And bracing can be quite contentious. So if you speak to some surgeons, they will be like, no, bracing's a waste of time. The curve's going to do what it's going to do regardless of bracing. And there are some people who say, look, bracing has its role, it has its benefits, and it's worth considering. So there's pros and cons. Personally, I do like a brace, but I think it has to be done at the right time for the right person. And that's where a lot of people kind of get it wrong.
Okay.
And that's most probably the important part. So I consider bracing to be a bit like doing bonsai to a certain extent. So you've got to have a person with growth potential so that you can guide the growth.
Yeah.
And that's what bracing does essentially. If you've already got an established curve and the person is done growing, or they're over that peak velocity, you are not going to make a difference because there's nothing to grow.
Okay.
So if you brace them for a long period and they pass that growth spurt, yes, you will see a correction if you x-ray them immediately because you've got a residual tension that holds on there. But if you leave that brace off for 1 day, 2 days, 3 days, leave that brace off for a week and re-x-ray them, the curve has started to return.
That quickly?
It does. So, but that is if you've already got that established curve and they pass their growth spurt and you're only starting the bracing protocol then.
Right.
Okay. If you can catch them early prior to that growth spurt and you can get them into a really, really good brace, I think there is a benefit. And a lot of the time, you can't really correct the curve, but what you can do is you can minimize the progression. So if you've got a 30-degree curve and you can keep it at 30, 35 degrees, 36 degrees, even if it gets to 40 degrees, that person potentially doesn't need a surgery. So
Okay.
they've still got a curve, but it's not in surgical kind of waters. If you've got a curve that's even less, obviously the better in there. So I definitely think bracing is worth giving it a go. The problem is that they have to wear it 23 hours out of 24. So you need a really motivated child, you need really committed parents.
Yeah.
And that bracing occurs over a number of years. So it's not something that is just going to be for 3-4 months. They are making a commitment to potentially 2 to 3 years in a brace.
Okay.
Sometimes longer. So this is a brace that is a big structure. It's made out of hard plastic. It gets sweaty and hot in Australia. Some kids then can't play sport. If they've got a whole afternoon of sport, 3-4 hours of sport, they can't do it. Some sports will preclude you playing the sport with the brace on because of fear of hurting, one of the other players if they collide with you or you fall on top of them and you've got a brace on. And then things like swimming become a problem because you can't swim in the brace. So essentially, they wear the brace the whole time other than personal hygiene, washing, showering, bathing, that kind of stuff. So it is a big commitment and they need to know that. And then some kids take it either way. So some kids are quite proud of their braces and they opt for quite a big decorative plastic, sort of camo, bold colors, that kind of stuff. And I've even got some kids that wear it on top of their shirts. They just say they don't like it close to their skin. They get sweaty, so they put their shirt on and then they put the brace on top of that, and they just sort of show it off and they're proud of it.
Yep.
And other kids are quite self-conscious about it, particularly the younger kids, when they're going through that settling into the peer group kind of thing. So there's a lot of factors to that. The other thing is brace hygiene can be quite challenging in terms of, sweating and stuff in it. So, you need to be able to wash it. You need to be able to dry it. You need the parents involved, because sometimes the kids can't care for it themselves.
Yep.
So you need motivated parents. And then the other problem is that this is the time the kids are growing. So one brace might not be enough. And through that life cycle, they might be looking at needing multiple braces, one, as the curve changes slightly with the growth, but also because they physically grow. And the brace works because it's very tight fitting. But because it's tight fitting, if they then get that little bit of adolescent podge around the middle, kids tend to kind of marshmallow out and then shoot up, and then marshmallow out and shoot up. Yeah. They find it quite uncomfortable. Mum and dad might have to then buy more than one brace, and that is a fairly substantial commitment, unless you can qualify for that brace through the public system, which not everyone gets funding, and not every hospital has the ability to fund that.
Right. And they'll be wearing that until what age?
So it's not necessarily age dependent, it's bone age dependent.
Yeah.
So it very much depends on their growth. So we mark this out. So we watch, when I say keep a close eye on the scoliosis, we keep a close eye on their weight, on their height, and we then track their growth rates, as well as the actual radiological changes. Radiologically, on the AP pelvis, you're looking at the RISA sign. And generally by the time they're a RISA 1, if they're a female, they're close to menstruation, in which case, if you've got a RISA 1, you've missed the curve. You're past it.
Okay.
So, and then if they've already started menarche, if they've started menstruating, again, their growth spurt is well and truly over at that stage. You've got a little bit of growth still to go, but not enough to make a difference with bracing. So you'd normally say to people, look, you've got maybe 1 or 2 centimeters of height in you, but the physis is normally starting to close. And on the AP pelvis, you can look at the triradiate cartilage. And if that's closed, again, their growing is done.
Yeah. Wow. Okay. So in terms of the different types of surgery now, if we get into that, how do you go about deciding, because there are different types of surgery, aren't there, at this stage?
There are. What I'm going to do is, let me just get up my PowerPoint, because I've actually got a nice little curve here, just going back to the growth side of things. I'm not sure if I can share my screen. Let me see if I can do this. So here we go. So if I share the screen here, you can see here what I've got on here. This is the growth velocity peak. So you can see here, this is where you've got your RISA 1. So by the time I've colored this sort of in orange here, which is where most females would start their menstrual cycle. And that's normally just towards the end of their menarche. So I think this scale that I've got here is maybe a little optimistic with the age, and that it's pushed out a little far. I would normally start the menarche. We see kids start menstruating even earlier than 12, but that's sort of about the average that we see. And you can see at that stage, by the time they hit RISA 1, you're well and truly over that peak, which means your ability to do anything or make a significant difference with bracing, you've really lost the opportunity at that stage. So for people who just need get their eye into the RISA gradings, there it is there. So it's on the physis, on the ASIS, on the anterior superior iliac spine, 4 levels, so 1, 2, 3, 4. And just basically, it's this little bit of ossification on the top that you can see there. So this is what it would look like through there. And you can see that through there. So that's a fully ossified 1 minute. So that's a RISA 4. And then RISA 5 is where it comes all the way back to there. So you could even argue that's most probably a RISA 5 at that stage. And then just very quickly going back, we're asking about progression in infantile kids. Sorry, that's Philip, by the way. Philip comes to theatre with me. He sits on the anesthetic machine and watches what I'm doing and checks that I'm behaving myself.
Yeah, good.
I don't know if you've heard about the rib vertebral angle in terms of predicting progression. So this is just another thing that you can do, particularly if you see a really young scoliosis. So you can calculate your rib vertical angle difference, which basically means you take your AP, you draw a line on the bottom of your vertebra, you draw a vertical line, so 90 degrees to your physis, and then you work out your convex rib and your concave rib, and you draw a line up the center of the rib, and you measure these angles. So if you've got a difference of 20 degrees between those angles, you're very likely looking at a progressive deformity. Okay. And then the other one is looking at the phases. So if you've got a slightly older child, if you then have an overlapping rib head on the convex side, again, that's a progressive curve. So those are two radiological features you can look at. It's only applicable to the infantile and the junior and the juvenile. It's not applicable to your adolescent idiopathic. But just if you do see someone who's very young, those are just two things to remember.
That's good. Okay.
Let me come out of it. And then, you were asking about progression. So I put this one in as well. So this is just your chances of progression associated with the ages. So this is, again, idiopathic adolescent. And that obviously the younger you are and the bigger the curve, the more likely it is to progress. So if you look down here, if you kind of take your 10 to 12 years, your smaller degrees at the older years are less likely to progress. So if you've got someone who's 16 with a 20-degree curve, yes, there is a small chance of progression, but it's tiny. It's really small. But if you've got a 10-year-old with a 60-degree curve, it's going to go rogue on you no matter what you do. And that's just the general principle. The earlier you see them with the bigger the curve, the nastier it's going to be.
Okay.
Okay, so let me just come back to Zoom. Okay, so, all right, so you were asking then about
the different types of surgery?
Yeah, different types of surgery. So when we've got the really young ones, we actually start off with casting, which not a lot of people know. And this is because they're in a growth phase. So we actually, just like bracing, it works exactly the same, except because they're growing so rapidly, you would literally be needing a new brace every 3-4 months, and it's just crazy. You know, parents can't afford it, kids don't like it. You need to be shaped into the brace. It's quite a big thing to have it done. And there's different types of braces that we do. So I've got a picture here. I'll actually share screen again with you guys so you can see. So this is what it looks like here. So we've got a little one on the table, and she's got cutouts here for the abdomen and for the rib, because we've got pressure areas that we're putting pressure on. So we're kind of pressurizing and offsetting. And this is what it looks like. So they stay in this for 6 weeks. And this is the correction that we got. So this was the first one that she had. And then this was the second round of casting. So this is within 6 weeks. And then, 6 weeks that comes off. We then do a lot of skin care. So when they're asleep, we take the plaster off, we bath them, we exfoliate the skin, we put a lot of moisturizer on them, we protect any prominent areas, and then we recast them again. So it is a little annoying for the children because they're in a plaster cast, but they actually adapt really well. They get used to it. Parents need to, take a bit of care, because we've had a few kids, like lose their dinner down their cast, or, you know, put money or favorite toys and stuff down. So we've always got to watch for that. But this is fairly effective for our really young ones because they're not really candidates for surgery at this stage.
So what age is this, Deb?
So these are young. So this young lady, I think, was about 4. And our other fella here is 3. So he's slightly different. This is a Minerva because it actually goes up into his neck. So you can see it's almost like a little collar as well as the jacket. So it's not just the jacket, whereas the one before just had a jacket, nothing up on the neck.
Yeah.
Whereas he's actually got a higher deformity. So controlling that deformity means higher control on the neck as well. If we find that we're not winning with casting, the next thing to do is growing rods. So growing rods work by literally doing pedicle screws at the top and pedicle screws at the bottom with a long rod that just spans the two. Now, if you look into the middle picture here, can you see my mouse moving?
Yep.
So if you look at the middle one, there's these little nut and bolts. And essentially, this is a male component that fits into a female component. Yep. And as they grow, every sort of 4 months, we get them into theatre. We make a little stab incision. And then we, so just a little stab incision over this area here. And then we put in spreaders and we can actually loosen up those. It's got like little bolts. We loosen up those bolts and we can spread that out so it accommodates growth. So you're not going to get that same crank shafting phenomenon that we get. And then as they grow, we just expand the rods on an expanding basis. So if you look at the one on the end, you can see that there's a slight difference in density. So there's a darker density and then a lighter density here. Mm-hmm. And this is where the male part has been moved up. So this was one that we brought in and we've expanded this up. And you can now see that there's a little bit of a gap. So that's how much that rod has been expanded by and then locked into situ until the next time. So it's a very quick procedure. So putting the growing rods in is a fairly substantial procedure, but then when they come back for the expansion side of things, it's literally a 20-minute job. They get an anesthetic. It's a little stab incision directly over that, expand it out, and then a couple of stitches and they're done. They go home the same day.
Right. So this is obviously a posterior approach.
Yep. So this is posterior. There are various other constructs which involve using the ribs, you know, with people with big deformities, but I've not included that as part of this talk.
Yeah.
And then if we then go on to surgery, we've got a variety of approaches. So we've got posterior approach, that is just, you know, person's lying face down and it's a long cut down the center of the back. And then we've got anterior approach, which is normally done with the person on their side. And then we sacrifice a rib. And even though it's called anterior, we actually position them sideways because of the heart and the lungs to protect that. But the construct is looking at the anterior side of things. Okay. And then we can also do that thoracoscopically with some kids. So if it's a smallish curve and very flexible, we can actually just do stab incisions between the ribs and use a scope and do everything via a scope so they don't lose a rib, they don't have this big cut. But if we do a big cut, sometimes we have to take down the diaphragm as well. So, you know, that is a big surgery to lose a rib, whole diaphragm take down, and then diaphragmatic repair as well. So, you know, obviously it's quite, I don't want to use the word brutal, but it's a very technically challenging and very big, serious surgery. So again, I've got some pictures just for you to see some of the planning that's involved. So what we normally do is do a plan on the board. So there's quite a lot of, we normally have a meeting with the team a week or two in advance where we go through the imaging, we discuss the case, what exactly we're going to do, what equipment we need. So all of that can be ordered in. And then on the day of surgery, we normally get down about 45 minutes to an hour before the person comes down, meet with the team, start opening all the trays, checking that we've got everything that we need, that everything is sterile and we've got all the right stuff. And we actually plan out based on the CT scans and the MRI scans, the size screws that we're using, where exactly we're going to put those screws, what's going to happen, you know, do we need a cell saver, what other equipment do we need? And this is just one little half of the theatre here, some of the equipment. So it's not unusual to have, you know, almost double or triple this amount of equipment out. But this was just the start of unpacking. So before I go any further, I've got some pictures of actual surgical photographs. So if anyone is feeling a bit squeamish, now might be the time to turn away. Are you happy for me to go ahead with some of those pictures?
Yep.
Okay. So this is in theatre. So this was quite an interesting case. And this one, we actually had to have special foam cutout made because the chest deformity was fairly significant for the padding. He had a very much a pigeon type chest. So we couldn't lay him flat on the table. So Sealy, the mattress company Sealy, actually did us a laser cutout. So if you look at this down the side, there's all these little numbers. So these were little thin films of foam that were each then laser cut to his particular shape. We did a surface scan of his chest and then bolted together so that we had this whole big support structure there. And then this is a halo to keep his neck, so it's pins into his head to keep him straight as we're working. We don't do that for all our scoliosis cases. This is obviously a bit of a special situation, but you know, he then had that done. This is now, half the wound is closed. We're in the process of closing this, but you can see again, this is posterior. These are some of the rods and the screws that are in. It's a very powerful construct. So if we're going from the back, we tend to use a 2-rod construct. So you'll get it's almost like a set of railway tracks that comes down either side.
Yep.
And these screws are what we call polyaxial screws. So we get screws that can move through 360 degrees to accommodate the rod, to accommodate the deformity. And then we've got other screws that are limited in their movement, so we can use them as an anchor to actually pull that deformity through. So planning out where you're going to have your more solid screws and where you're going to have your more mobile screws becomes quite important in terms of correcting that deformity and shaping your rod. So, sorry, I'm just going to take the volume down here. So what I've put this in for is you can actually see here, this is fascinating. You can see that little pulse that's happening there. And that is actually your CSF pulse. So looking through here, where that suction is actually dura under the side, and that central bit, that little clear tube, is the epidural that's now going in, and that's actually a CSF pulse that you're seeing. So that whole gap, so just to the left of that tube and the center line in between those 2 rods, that is all exposed dura.
All right. Okay.
So I'll just play that again just because I find that fascinating. Just again, looking at that CSF pulse. So your CSF pulse is totally independent of your cardiac pulse.
Yeah.
And it's just there, and it tells me that that cord is working nicely. So it's one of the simple pleasures I have in life is looking at the CSF pulse. So anyone who disputes the fact the CSF has a pulse, it most definitely has a pulse. Most definitely has a pulse, and there it is. So that's actually what it looks like.
Is there another pedicle screw that's due to go in there, or do you sometimes miss a level? Do you put
No, we actually miss levels. So if you go back, I'm just trying to see if I've got, I'm just going to stop sharing for 2 minutes just so I can look through some photographs quick and see if I've got another plan up. So I'm just going to crop this very quickly because I've got a name on here and I just want to keep it. I just want to keep it anonymous.
Yep.
So I'm just going to crop this down very quickly. So we're missing some of it. So you can see here, so we actually, this is again another surgical planning where we've actually planned to miss out some levels. So here we've got more instrumentation on this side and less instrumentation on that side. We're going down to the iliac crest here. So this is a neuromuscular curve. But this allows us to, because we've got more on the side, to actually crank that deformity over and really do that correction. So we've got some really strong pillars and some bases to work against, and then to actually do that reduction, pulling it across.
Okay.
So yeah, it's quite a there's a lot of, I don't want to use the word force, but there's a lot of power in those posterior instruments to actually correct that kind of deformity. The neuromuscular curves are quite rigid compared to the idiopathic, so we don't get the same correction as we do on the idiopathic. But it's good. It's good either way.
So there is a question. There is a question here that goes along those lines. So they're saying, does the severity of the deformity depict what type of surgery is chosen? Are there particular benefits or longevity of one particular surgical approach?
So not longevity, but certainly, the different approaches do actually have different benefits and pros and cons. So this was the correction that was done. So essentially, when you do a correction, it's not about the longevity, because essentially you're expecting the metalware to fail. What you're doing is, when you do the surgery, you then are starting a race between the metalware failing and the spine fusing. So any kind of scoliosis correction, other than the growing rods where we're not fusing, but on these corrections, it's a fusion surgery. So you want to fuse that spine. Now, the metalware has got a certain amount of tolerance, a bit like if you get a metal coat hanger and you bend it. It will only bend so many times before it breaks. And it's the same with this metalware, regardless of the construct that we use. So we need that spine to fuse before the metalware fails. And if the metalware fails, it's generally because there's been added movement somewhere, i.e. it hasn't fused. So that is with the main construct. The main problem that we have, if people have problems with scoliosis, is generally because we've now got this very rigid spine that you start developing adjacent segment disease. So it's the levels above the fusion and below the fusion that then have to, do a huge amount of work that they're just not structurally designed for. And then they start developing pain because obviously those joints become arthritic. So it's a combination of, making sure that you do your fusion at the right levels and the optimum levels, and that you keep your construct as short as possible. You don't want to just go doing a long fusion because you fancy doing a long fusion. You want to try spare as many joints as you can. So if we can end at L4, we would try to end at L4 rather than going to L5. If we could end at L3, that would be even better. In terms of taking it up, again, a lot of the time we take it to either T5 or T3. But if it doesn't need to go that high, and we can get away with something lower, then that's obviously what we would want to do. So this is where a lot of that pre-workup comes in. So it's not so much a longevity thing in terms of the construct. It's more that, does it fuse? Do we not have any failure of the metalware because it hasn't fused? And then further down the line, And we counsel people that they are going to get problems above and below. It's just the nature of the beast.
Okay. So, so with that, do they still do sort of wedge osteotomies and that type of thing? Or is
We
that
do. No, we do, but that again is a slightly different animal. What I'm going to show you as well, just talking about sometimes, this was the posterior construct. So you can see that there's two rods like a railway track.
Yep.
There's some, the other one is the thoracotomy and the discectomy. So this is the anterior approach. And this is where we've taken a rib down. So often what we do is we harvest that rib and we use that rib for bone graft. So we take out the discs. That's part of the scoliosis surgery from the front. So from the back, we leave the discs in, but we fuse the joints at the back because you've got access to the facet joints, and we use the spinous processes as bone graft, and we break those off and we use those to add to the fusion. If you're doing a thoracotomy, so an anterior approach, we actually do a discectomy, take the discs out, and then put bone graft into those spaces to help the fusion. And often this is just a much smaller construct, and we only use one rod for this. If we've got to take the diaphragm down, that's another whole beastie, and then they need a chest drain. So I've got you, let me just check what I've got. So I've got this is some video. So again, anyone who's not keen on surgical procedures, look away. This is actually a thoracotomy. We're in the chest, and I'll show you some of the anatomy that we've got. So if we look at this video, this is us doing the discectomy. So you can see the lung poking up over here. The heart is behind this big sponge. And we're now, this is the vertebral body there, and here is the disc coming out. And the nice thing with this is you can actually see, because it's a young disc, if you look closely, you can see the layers of the annulus, and you can see part of the nucleus coming out. So this is now next one. So again, using the pituitary, you can see it coming out. So it's quite fibrous. This is a young disc. And again, the heart is sitting behind here. You can see it pulsating, and there's the lungs coming up through there. And then, so again, this is just the next level down. Again, a slightly closer view of that discectomy. You can see it's quite solid going through that annulus. It's a very solid structure to come out. It's one of those where it's such a pity to see this beautiful tissue coming out, but it's amazing to see the anatomy, the actual parts coming off. And then I've got here. I think this shows you again, it's just slightly closer. It's a bigger disc. I was trying to actually get to see the layers here. So I'm zooming in a bit, and you can really see those layers of the disc.
Yeah.
So down below here, we've already taken that disc out. There's a little bit of graft sitting in there already. Heart is sitting under here, and then that's the lung poking up over the top.
So how many levels will you do that at?
So it depends on the curve, how many levels we're wanting to do. So yeah, it's all pre-planned. So we know exactly what we're going to do and what we're not going to do. And then, again, this is just, I've got some of the discs, just again, sorry, because I just thought it's just nice to look at the anatomy. Yeah. You can see those layers, and then that's nucleus. through there. Kind of looking around at that. You know, you don't often get to see that. So in an adult, you wouldn't see those layers. It's just all fibrous and mushy. This is your nucleus sitting through there. So you can see that very different texture. That's there. And again, just some more, again, just in a bit more detail. Again, that difference between the annulus and the nucleus is quite marked. And again, it's just because we've got nice, youthful anatomy. So I just put that in case people were interested. So yeah, so the X-rays for an anterior, look, let me just find it. Look like this.
Yeah.
So a very different X-ray to what you had. So the posterior approach has got the two railway tracks coming down, whereas your anterior approach has just a single rod construct. So if you see this X-ray, then you know that they've had an anterior approach, and you can see it's a much shorter construct as well. So if you've got a short thoracic curve, that's normally a good candidate for an anterior approach. But if you've got a really long double curve neuromuscular, you know, that's going to be more the posterior approach. And then the other option that we have, which is becoming more popular, is tethering.
Yeah.
Which is this.
Yeah.
So this is now tethered. So this was a compensatory curve on the lumbar, and you can see here how it's straightened out. You can see that the correction isn't as good with the tethering as we did with the anterior fusion, but that's because this person will be younger, and tethering is again like an internal brace. So in order to qualify for tethering, they must still have growth potential, because you're wanting to just guide the growth as they grow. So this isn't a fusion procedure. So with tethering, we don't take out the discs. We just put the screws in, and then there's like a very strong tape that goes down. So where you had the rod coming down here in the fusion is just a very, very strong tape that just basically pulls that vertebra. So as they grow, it just holds it a bit like a mainsail. And then when they reach a good correction, we just go back in with a scope and we cut the cables.
Right.
So they don't actually have a fusion.
And so once that's completed and they're through their growth phase, do they have better mobility?
They will, because it's not fused. So they will essentially have a normal spine, but straight.
Okay. So how do you choose between this method and the full rods and that type of thing?
So a lot of it is about having them present at the right age. And this is what I was saying. It's that important, even when you see them young, that you get them seen, because even though they might be doing well with chiropractic care, you know, if you hold on to them and no one knows about them, they may miss the opportunity for this kind of surgery, and then they end up having to have a fusion where this could have been possibly more appropriate. The other thing is that for this to happen, you need someone with the right skills. So they need to be able to do this thoracoscopically. So this isn't an open procedure. It can be done open, but the whole idea with this is that it's done thoracoscopically, just through stab incisions using a scope through the chest. So you need someone specifically trained in this, and it's very technical. And then you need to have the right curve. So you need to know that, you know, it's not going to work on a lumbar curve. This only works on thoracic. It doesn't work on lumbar, doesn't work on cervical. So yeah, you need to have a curve of the right stage, essentially. Whereas if the person's past their growth spurt, if that curve is solid, if that curve is too big, then, you know, that they're looking at a fusion.
Wow. Okay. And so in terms of I guess I don't want to get off the surgery role too soon, but if we can go through sort of post-surgery recommendations as well at some stage, that'll be great.
Can do. You just reminded me, you were asking about the wedge resections.
Yes.
So we do them, but those are more for your neuromuscular scoliosis with severe deformity.
Okay.
We wouldn't be doing wedge resections on an idiopathic scoliosis.
Okay.
We do the normal term for that would be an osteotomy. And we would do that more in the adult degenerative or in the neuromuscular. Or we can do vertebrectomies or corpectomies, and that's sort of removing whole vertebrae or wedges in there. So also with congenital. So for example, this was a case that we did. So this is the kind of deformity that you're looking at, you know, severe deformities. And this was one where we actually took the vertebra out. So again, pre-op planning was fairly significant. We got 3D models made. So this was in theatre with us. So we could actually look at this while we were working to know exactly where we were and with our planning. And then this is that actual vertebra now during our dissection. That's that vertebra sticking out. And then this is us actually removing that vertebra. So we've actually cut the dura, we've cut through the cauda equina. This person was paralyzed anyway. So us, you know, we're not creating a neurological deficit. They were paralyzed and in the chair. But this is the top part of this is the vertebra above with the thecal sac under there. And then that was split to remove all of that out. So difficult to see through there. But again, there's some surgery coming. So look away if you're a bit squeamish. Let's get this up here. So this was us actually removing this out now. So you can see that coming out.
Wow.
So it's a big part through there. And then we got rods in, top and bottom. Top and bottom, there's the defect through there, and then that was it at the end.
Yeah, right.
So this child had been having big problems with pressure areas, skin breakdown because of that big kyphosis. And then, you know, flat, obviously, at the end. This is like a dual construct. So you can see there's 4 rods there, two rods there and 2 rods there, and then a single rod here. These are cross connectors. So those were cross connectors that just help give us a little bit more strength. So we are still doing those kind of surgeries, but again, you know, very specific instances. But that I thought was quite quite interesting. Yeah. Okay. So you wanted to know about post-op care.
I guess as long as we're not moving on too quickly.
No, that was it. Sorry, it was me. I was sleeping. I should have gone through that a bit quicker. But yeah, post-op care is great from a chiropractic point of view. I mean, obviously the big thing is you've got a long construct that's fused. You're not going to move that. We don't want you to move it because the whole idea is that it's fused.
Yeah.
But, you know, things like looking at the pelvis, looking at the neck, looking at the paravertebral muscles, looking at the ribs anteriorly, all of these are affected and very important to work on as well. And the things I found the most effective is the rib work, because they do get a lot of pain from that because they've had the rotation. We no longer do the rib resection. So about 15, 20 years ago, it was quite common to actually cut the side of the ribs, and that was to make the deformity more flexible. But we found that over time that didn't really have much longevity in terms of that rib deformity just came back, and they were very sore with that sort of mobile chest cage. So we don't do that anymore. But it does mean that as we've derotated that spine, you know, those joints, those costovertebral joints are very stiff and they can get quite sore in the front as well. So, you know, working on the ribs, working on the first rib, again, is quite important. And then, you know, really good work on the pelvis, the sacroiliac joints, the cervical spine, I think is invaluable.
Yeah. And I guess with these types of things, the chances of things progressing above and below the level of the fusion, is there anything around that in terms of the chances of that happening and, you know, people having to have other surgeries?
So generally not, unless we have done a shorter fusion and we've said to someone, look, we've tried to keep it short and we may need to do something in the future because we don't want to do it particularly long. So generally by the time we operate for an adolescent idiopathic, they pass their growth phase. So
Yeah.
developing any further deformity really shouldn't be too much of an issue.
Yeah.
If we've got a neuromuscular child or we've done it earlier, then yes, that is at the back of your mind. But most of our adolescent idiopathics are only really coming to surgery age 15, 16. So they should be well and truly over their growth spurt.
Okay.
We do counsel them about the risk of adjacent segment disease. And if that is the case, we may have to extend. So if we've finished at L4 and they start developing L4, L5 arthritis, we may extend down to just incorporate that into the fusion.
Okay.
Or if the other risk is at the top, really, the thoracic area, they develop sort of a junctional kyphosis. It's more of an issue in our older people and in neuromuscular people where they just don't have the muscle control and they don't have the muscle strength. And they develop sort of this, you know, sort of front deformity as they fall forward. And if that's the case, we may have to extend it up. But it's not, you know, I would say that's less than 10% of the cases that we do, if not even less than that.
Okay. And is there any role in exercise, like pre and post surgical exercise? Is there any evidence for the benefits of that?
So there's evidence in terms of coming into the surgery stronger, having a better resilience to the anesthetic, and making a faster recovery in terms of mobilizing post-op. The other thing that we find is that people or children who engage in an exercise program preemptively find that they know what's expected of them. So the exercises are familiar, particularly if they get started on that preoperatively. It's not like learning a new exercise. They already know how to do it. They've got some of that muscle patterning there. Yeah. So they engage in that a lot more willingly and are a lot more motivated because they've kind of started the process of rehab already. Sometimes the kids that haven't had that opportunity are very reluctant to get out of bed. They're quite scared about that process. They're quite, you know, the thought of doing an exercise that they don't know how it's going to work. Is it going to hurt? You know, all of that kind of stuff. So we definitely find from a motivation getting into the swing of things a lot better. Yeah. In terms of making the, you know, essentially all we want is that bone to fuse. So that boils down, I think, more to nutritional basis, protein intake, you know, appropriate supplementation. But in terms of having any addition to the surgery, I don't know, because, you know, we've got such a strong, powerful construct. Yeah. I don't think muscle strength or core conditioning is going to make much of a difference. But certainly in terms of, you know, just keeping good condition, it's good because it's a prolonged recovery, you know. So we, you know, if they go into it nice and strong and they can walk quickly and get up and about, that's definitely an advantage.
Yeah. And we didn't really cover that. You say a prolonged recovery. So if we're talking to people that we're seeing and they're going in for this type of thing, what sort of length of time are we saying, you know, that they're going to be held up for, and how long is it going to be until they're, you know, 100%?
Yeah. So depending on what surgery they have, their surgical stay time is different. So it will depend on, you know, what surgery they're having, and that would be a discussion with the surgical team. Often our thoracotomies go to intensive care for a short period. And some of our wards actually have almost like a high dependency unit set up where they've got, maybe 2 or 3 patients per bay, so it's not your usual packed bay. Normal surgical stay is anywhere from, sort of 4 days for some of the thoracoscopic work, up to sort of 10 days for your adolescent idiopathic. Most kids go home round about the 5 to 7 day mark. It's normally the criteria for going home is that the wound is nice and dry, that they can walk around, they can get on and off the toilet, on and off the bed, that kind of criteria, which is slightly different for everyone, but round about the 5 to 7 day mark.
Yeah.
Neuromusculars stay longer because we have to do wheelchair adaptations. They've got to see physios. We've got to have home help put in, that kind of stuff. So that takes a bit longer. We normally say that they would be up and walking the next day following their surgery. They're normally walking independently by about the 7 to 10 day mark. And they're normally back to most of the usual activities round about the 8 to 10 week mark.
Okay.
Some kids bounce back really well and are doing most of the usual activities by about 6 weeks. But that I mean by walking and round the house. I'm not talking sport.
Yeah.
We then say to them they can normally go back to school whenever they're comfortable. And for some kids, that's the 6 week mark. Some kids, it's more the 10 week mark. Most kids are back at school by 3 months. We normally do a phased return to school. And that's because they get quite fatigued and quite tired. And it's things like sitting for prolonged periods can be challenging, and carrying a backpack, that kind of stuff. So we've got to educate them about options for, carrying their bags, getting up and downstairs, that kind of stuff. And then back to sport. So no contact sport for 12 months. And normal sport. So if they were, playing gentle netball, or if they were, maybe, I don't know, doing some swimming kind of activities, they'd be able to do that from about the 4 to 6 months, provided there's no complications with the wound. But anything contact in terms of running, contacting with other people would be 12 months.
Okay, that's great. Well, I don't have any other questions. If there anything else that anyone else wants to ask, or if you've got anything else that you think we should cover, Deb?
I don't have.
There was some questions in the Q&A in the chat. I don't know if you guys have answered those yet, but Catherine asked.
I'm just having a look.
Oh, you can see that.
Ken is saying right thoracic curves unusual. It's the left thoracic curve. So right thoracic curves are the common ones. It's the left thoracic curve that's the unusual one. Other issues, yes. So there's quite a lot. So what we do is we normally start off, looking at the feet. Sometimes they can come with other structural abnormalities. No worries, Ken. I made the same mistake for ages as well, particularly if I'm looking at them the wrong way around. So normally looking at the feet, because that's quite a big clue that there's something else going on. So particularly high arched feet. Have they had a issue with club foot when they were born? Do they have any hip dysplasia is the other thing that we worry about and we look at. So particularly women, so, adolescent female, scoliosis, do they have ligamentous laxity? Were they first born? And all of that is also your risk for DDH in terms of hip dysplasia. So, you've got kind of a perfect storm there. So when you see any of these kids and you x-ray them, always look at the hips, make sure you're okay with the hips. We normally talk about Vactral and Vata. I'm sure you guys have heard about it, but for those where it might be a bit far off, your Vactral stands for vertebral, anal, tracheoesophageal, E, and then R is renal, cardiac and renal are your main things. So if you just remember Vata and Vactral, that will give you most of the abnormalities that we screen for. So anytime you see a scoliosis, just make sure you ask those questions. Make sure if they've had, any cardiac surgery. Again, if a child has needed cardiac surgery, there's often issues. Your average kid doesn't need cardiac surgery.
Yeah.
And it's always worth asking, is there a family history of scoliosis? Particularly first degree relatives. and whether they had surgery. So that's often a big predictor of whether that curve is going to progress. Because if mum's got scoliosis, but it was very mild and she didn't need any surgery, it's less likely that the curve is going to progress. You still have to watch it. You still have to have all the concerns, but at least you've got a ballpark. But if someone says, oh yeah, no, mum's got it and auntie's got it and grandma had it and everyone's got it, you kind of, there's a strong family history here.
Yeah. Okay.
Yeah. And there's one from Catherine. Does the severity of the deformity depict what type of surgery is chosen? So we've answered that. So yes, so obviously your longer, bigger curves do better with posterior instrumentation because it's very, very powerful, and we can correct, double curves. We can really correct a lot of the deformities. Your smaller thoracic curves do well with anterior, as it does for tethering, but whether we do the fusion or whether we do tethering depends on the age.
Right. That's good. I don't think there's anything else. I think that's kind of it.
Yeah, no worries. And we've stuck down to how we're doing time-wise. Have I bored you guys silly? Oh, it's an hour and 10 minutes. Okay, so
Right.
not quite a marathon, but long enough.
That's great. Well, thank you. Thank you so much for taking the time to do this. So I'm sure there'll be a lot of people that'll really benefit from it. Yeah, it's great to have you on again.
No worries. If anyone's got any questions or they want to chat, just I'm more than happy to take an email or a message via Facebook. Sometimes I'm a little slow returning stuff, so please be patient. And if I've forgotten about you, just message me again. As I said, I sometimes get a little bit forgetful, but more than happy to answer questions and stuff. And if anyone wants to do another Zoom session, get in touch. We can do stuff. So there is a lot more to talk about with this. It's a big, big topic, but hopefully it's useful.
So what would be the next things that you would talk about, Deb?
I think it would be more kind of the adult side of things, so what happens if people say they're not going to have the surgery? So we have two types. Either the parents say, look, it's not something I'm prepared to have my child go through. It's too big a surgery. It's not what I'm interested in. Yep. Or you have that 40-degree curve that isn't quite bad enough to do surgery, because we only really look at doing surgery from 50 degrees onwards.
Yep.
So, if it's that 45 degrees that didn't quite get surgery, then, what happens to them as an adult if they have problems further down the line. And then also your degenerative curves that, they've never had a problem, and then all of a sudden they hit their 60s and their 70s and they start developing deformities. What we do then, because that's a whole different animal.
That sounds good. That'd probably be a really good one to do. Excellent.
All right, no worries. Cool. Well, thanks very much, Dawn, and thanks for organising everything, Matt.
No worries.
Thanks, guys. It was great.
Thank
you.
you.
Take care. Bye. Bye.